Okay.
If we're going to do that, we probably need to take a roll call attendance for REMAC so that statutorily we have a quorum and we can do business. The votes will be for both REMAC and medical standards people. The discussion will be open to anybody, but we'll have to, the counting votes for REMAC would be REMAC members only.
Absolutely. So Marie, would you like to do a roll call before we start?
Marie, the roll call is
Yes.
for REMAC members is what we need.
Oh, you
Anybody
don't
can be on
want,
the call, but we need the REMAC list.
okay, but you don't want me to do attendance for medical standards?
You can, but we don't need to for statutes. For statutes, we need the REMAC attendance.
Maybe we should just check the attendance also for medical standards, and yeah,
That's
and
what
then
we've
we
done
can.
We've done it at the other meetings. We'll do medical standards first, and then I'll do REMAC.
Perfect.
We'll do it quick. Okay, so please unmute yourselves and respond when I call your name. Paul Barbara.
I'm here.
Great. Okay. Jonathan Berkowitz. Cindy Basilios. Harry Koplovich. Joseph Bove. Neil Semilovic.
Present.
Thank you. Wallace Carter.
Present.
Robert Krupe.
Here.
Jeffrey Douglin.
Lauren Kosterko.
Okay, Lauren, thank you. Sorry. Reed Caldwell.
I'm here.
Jonathan Washko, are you here? Jason Zimmerman.
I'm here.
Oh, I have two of them open. I feel like.
David Lobel. David Eng.
I'm here.
Is Matt Friedman here?
I think he's in the chat also.
I'm here.
Thank you. Jeffrey Rabrich.
Here.
Thank you. Michael Redliner, I think he said he couldn't be here tonight. Mike, are you here?
He's not.
Joseph Schenker?
Here.
Schenker.
Anthony Shalish? Rafael Torres? Okay. Jason Zimmerman?
Here again. That's twice, Marie.
Yeah, I have you on twice. I don't know why. Okay. Nick Alexandru?
I'm here, Marie.
Glenn Esteda?
Here.
David Benelli?
In favor.
Dr. Gonzalez?
Here.
Doug Isaacs?
He'll be joining us in a little bit, Marie. He's running a little late.
Okay. Brad Kaufman?
Here.
Anne Marie Grigenti?
Here.
Kevin Ward?
Here.
Grace Cacciola?
Here.
Madeline Fong? Sean Graves?
Present.
Michael Vatch or Robert Ackerman?
Robert's here.
Thanks, Robert. Morty Lax? Arthur Cooper,
Here.
thank you. Yadidja Langsam,
Present.
Lewis Marshall, Kevin Munjal,
Present.
is that you, Kevin?
Yes, that's me. Present.
Thank you. Jessica Van Voorhees. Okay, now that was medical standards. Let me do REMAC. You may be called again, just answer again. Robert Winchell. Joseph Schenker,
Here.
Robert Ackerman,
Here.
Nick Alexandru,
Here.
Eric Cohen.
Present.
Great. Kevin Munjal. Cindy Basilios. Grace Cacciola,
Here.
Dario Gonzalez,
Here.
thank you. Glenna Seda,
Here.
Brad Kaufman,
Here.
okay, Doug Isaacs is coming. Nathan Reisman,
I'm here.
Kevin Ward,
Here.
Anne Marie Grigenti,
Here.
Samia McEachin, Allison Burke.
I'm here.
Hi, Allison.
I'm just getting set up, just got to a computer.
Okay. Jeff Rabrich,
Here.
Reed Caldwell,
Here.
Jonathan Berkowitz, Lewis Marshall.
John's coming on.
Oh, it is? Okay.
Marie, you can't take a roll call vote, but people who are coming.
I'm not taking them until I hear them say that they're
Record
here.
it. You can't do this type of stuff. When people come in, they have to identify themselves. Otherwise, it'll be all illegal, the whole meeting.
Okay,
Okay, hi, it's John Berkowitz.
thank you.
Thank you, John, for identifying yourself.
Lewis Marshall. Michael Redlener. Oh, he's not here, I'm sorry. Laura Ivacoli,
Here. I'm here.
thank you. Stuart Kessler,
I'm here. I may have to be off and on the video because I have to drive, but I'm here.
okay, yeah, don't have an accident, please. Matthew Fink. Wallace Carter.
Here.
Dominic Battinelli. Efren Rendon. Peter Wire.
Here.
Thank you. Paul Barbara. Paul Barbara.
Present.
Okay.
Sorry, I was
David-
on mute.
That's
Present.
okay. David Benelli.
Here.
Celia Quinn or Timothy Stiles. Okay. Mark Cantor.
Here.
Dr. Bove, Joseph Bove.
Here.
Okay, great. And Sean Graves,
Here.
William Fisher,
Here.
Robert Krupe,
Here.
Jessica Van Voorhees. Arthur Cooper.
Here.
Yadidra Langsam.
Present.
Anthony Shalish. Okay, is there anybody here that I did not call?
This is Pesach. I'm here.
Thank you, Pesach.
Josh Buckland.
Okay. Okay, I'll put you down as guests. Okay, we have a quorum.
Thank you. All right, Dave, your show.
Okay, now that I'm unmuted. Okay, so good evening again, everyone. We're going to start with medical standards, and we'll then hopefully be able to vote on anything that's brought forward for both committees, and then progress to REMAC issues as well. So everybody, I'll start with a motion to approve the minutes of the last meeting. I know that Maria sent them around. Is there any discussion about this? If not, I'll accept a motion to approve the minutes.
Motion to approve.
Okay, is there a second?
Second.
Very good. I'm gonna just save the voting on this. Is there anyone who objects or would like to discuss this? If not, we'll take this as, if Yadidra thinks it's okay, we'll take this as, thank you, Yadidra. We'll take this as approved, that the minutes are approved. Marie, let's proceed with the correspondence report.
210.
So David, I have the correspondence report right
okay.
here. For the purpose of, again, the correspondence is really to both committees, but it's for being read in for the purpose of REMAC. There was no new membership correspondence, no correspondence from the fire department. A certificate was surrendered effective 10/21 for Neil Toom from Portchester, EMT number 410570. There's been communications between NYSVARA, District 4 and 18, and Bedford-Stuyvesant Volunteer Ambulance Corps, identifying issues that need to be corrected before that corps can be operationalized. There was an email that came from Dr. Levitan for a patient transport without a wheelchair, and asked that if there's a REMAC policy about that. Again, I saw the correspondence about this. I would say that we should probably discuss this with the agency itself, not necessarily. I would save the correspondence with Robert. I see your hand. I'll call on you in a second. I just want to get through the correspondence, and then I'll let you comment. And that actually concludes the correspondence. So Robert, you wanted to say something. You're muted.
Thanks very much, Joseph. So the concern we're having is that it's not just one agency. We're noting this with many agencies. Glenn Assato was extremely helpful in correcting this issue we had with the fire department of New York, but there still are issues with the other agencies. And we thought that if we could have a policy at the REMAC level, at least the other agencies would understand what the requirements were. To not transport an individual with a wheelchair who is disabled or other accessible device is really not appropriate. And to hear excuses, the wheelchair was broken, blah, 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 I don't think that's the kind of care we want to give to our citizens and our communities. So I'd really like to see something a little bit, well, I'd like to see a policy such that when I get, and I won't mention names of agencies, when I have an agency who transports an individual who's disabled without their accessible device, that I have some teeth to go back at the individual and say, come on, I need that wheelchair. Wheelchairs cost anywhere from $1,800 to $3,200. It's a big expense for replacement. even if the wheelchair is broken, I can have it repaired much less cost than I've had to replace it. So I would like to see some conversation from others, whether you're having this experience or not. I want to thank my colleagues at Fdny for fixing this on their side, but I'd like to see some teeth in it for the rest of us. Thank you.
All right, Sean, you raised your hand.
Yeah, just in the response to that, I think in terms of it being an operational concern, I think that it's usually centric to securing the wheelchair in the ambulance. The inability for the crew to sometimes secure a wheelchair effectively in an ambulance. If the ambulance is involved in a motor vehicle accident and the wheelchair is not properly secured, that could be an issue. I don't know if the fire department has anything on the GOP regarding that. I mean, I guess they can speak to that. And additionally, I think if any language does end up into the GOP or our standards or our protocols, that it would be centric to kind of draw a line in the sand to what type of device that would be. Obviously, we don't want crews out there trying to lift up mechanical wheelchairs that weigh in excess of 100, 150 pounds. That would be unsafe for the crew. So I see where the concern is, but I think we should address those as well.
So again, and Glenn, you can comment the best to this. The fire department GOP does have standards for managing all of those scenarios. There actually is a, for lack of a better word, a bariatric ambulance or a transport vehicle that will pick up these larger than usual vehicles or devices. Look, I spent a lot of time with the disabled community. I'm a disabled sailing instructor. And I've got hundreds of people across the United States whose equipment is extremely personal and important to them. To transport an individual to a hospital emergency department without their device is really not the right thing to do or the kind of care that we would want to represent. So perhaps we want to look at this a little bit more closely, but we can't just leave equipment in the street.
So
we just can't do that.
So Grace, you have your hand up, and then after that, I think we should take this to a smaller group to discuss and probably come up with something. But I think, we all agree that doing the best care is appropriate. It's just I'm not sure that we want to have this whole discussion here. Grace, go ahead.
Perhaps this should be addressed also at REMSCO. I mean, this is definitely operational.
Right. Our first request is to NYPD to secure the chair and transport it if possible. If they cannot, we do send out the bariatric ambulance to transport it for us. We usually do not like to abandon the patient from their chair. So again, the first course of action we have is request NYPD secure it. If they refuse, we make a special call to the bariatric ambulance. We used to send out the MERV or the Me Too, but it's just too big of a vehicle for one wheelchair to deploy it.
Okay. All right, so let's take this to a different place. I'm not sure. I agree with David. I think this is more operational, and maybe we should forward this to REMSCO to discuss. Did you? Is that okay with you?
Forward it to the ambulance committee of REMSCO first.
Okay,
perfect.
Can we do that? Thank you.
Thank you very much, everybody.
Yes, you can.
All right, that concludes the correspondence, David. We can move.
Thank you very much. Okay, so let's move on to the Cnc Committee. Paul?
Good evening, everyone. Cnc met remotely. I want to say, hold on, October 16th and October 2nd. Topic of conversation is essentially the exam and ensuring the updates to the exam reflect the protocol changes. I believe I discussed this in the last REMAC meeting, but if not, if there's any new ears, there's no intent at the exam level to have any discrepancies between the current protocols and the upcoming 2021 protocols. It is part and parcel with the exam that you're taking that it reflects the protocols that are in place that day. But anything that's a hedge factor between a now or in January, it's been removed. We plan after the January launch to have some data on the changes to the exam. It's just too many moves right now to run data and demonstrate the exam itself. There's no issues with the exam being delivered in a COVID-free or sensitive environment. And if anyone has any other questions about the exam, Mr. Ward is on the line, sporting a nice beard, and he can answer them.
All right, I don't see any hands up.
Okay, so if there is there any discussion regarding this report? If not, we will move on. Very good. I'd like to ask John Berkowitz, if you're on the line, just to give us a little preface regarding the interfacility protocol committee. If you can update where we stand with this.
Sure. Thanks, David.
Sure.
Established a Google Groups with some resources that's meant to guide this process. I would like to put out kind of a call for the membership for this committee. So you can email me or Marie or Joe, I presume. But if you're interested in being on, I need to get an established set of members, and then from that I will.
Marie.
Hello.
Yeah, go ahead, John.
Yeah,
go ahead.
To get an established set of members before we can start having meetings, but I've already started to put together some documents and a framework to move forward. So that's the next thing that I've requested. So if I could get assistance with that, then we can move forward.
Yes, Marie's raising her hand.
Hi. I did send out an email to all the REMAC and medical standards members. I've gotten a bunch of responses. I will put together your interim membership list. So as soon as you're ready, we can start sending out invites for meetings.
Perfect.
Okay, any discussion about this?
Anybody else who's interested, please do send an email to Marie. The more involvement, the better.
Right. Just there's a couple of things I'm hoping to accomplish. One is I do want to get an understanding of kind of a needs assessment. I do want to get look at kind of what's the history around what has been attempted in the past in terms of REMAC involvement with interfacility, and then we're definitely going to need to have a kind of a regulatory discussion to better understand what we can and cannot do. That's kind of the beginnings of the kind of the framework that I'm hoping to approach this topic with.
Very good. Any discussion?
Yeah, it's Robert again. Is there a charter or a mission statement for the project?
So I think that based on those elements, we will be able to put together a charter. But to make a charter without kind of having thought what the needs are from the crews doing these transports, nor to think about what is allowable from a regulatory standpoint, wouldn't make sense. So this is almost the first thing I would like to do is kind of establish that part, and then we can put together a mission statement that would be practical.
Thank you.
Any further questions, discussion? Okay, good. So let's move on to the protocol committee. Dr. Lai, if you would like to discuss what's being brought forward to the Medical Standards Committee and to REMAC.
Sure. Thank you, David Minelli. So since the last REMAC meeting, the protocol committee met on October 30th via Zoom, where we were tasked with revising the general pain management protocol, which was proposed during the last REMAC meeting. As you can see, like from the agenda from the protocol meeting that was sent out to everyone, we did address the issues that were brought up during the REMAC meeting, where we addressed the standing orders of the opioid medications, as well as the dosing for ketamine, as well as the inclusion of acetaminophen. For those physicians or for those people that were not present during the meeting, we did discuss the issues that were raised from the last REMAC meeting.
Hey, Pam, so if share your screen.
Yes. Oh, I actually do not have the protocols up right now. I would have to go and grab
a. Maybe Marie has them up, or Joe. Maybe you can pull them up.
Joe Ranieri, do you have them available?
Joe doesn't have them.
All right, I will pull them up. You keep talking. I will get them up in a minute.
All right, perfect. So with that in mind, so we do have two protocols to bring to REMAC for discussion today. So one of them is the general pain management protocol, as well as a new protocol that we will discuss soon thereafter. So while we're waiting for the protocol to be shown on the screen, we continue to have as the paramedic standing order options for the morphine and the fentanyl, as well as the ketorolac and also acetaminophen was discussed at length and was decided to be kept into the protocol with the dosing that will be shown on the screen shortly. Also, I'm sorry.
No, go ahead, Pam. Go ahead.
Okay. So in addition, under medical control options for the paramedics, we continue to have the additional dosing for the opioid medications, the morphine and the fentanyl, as well as a option for the ketamine, with the dosing that was adjusted as this was brought forth from REMAC, where we actually did have a lot of the physicians that did have some concerns with the dosing present at the protocol committee meeting. The other things in terms of the key points and considerations were mostly the same compared to the previous protocol that was brought forth to REMAC during the last meeting.
Okay, and this protocol was emailed to everyone by Marie. This protocol and the next protocol that you will discuss was sent by email to everyone for review before this meeting. So let's, is there any discussion about this, the pain management protocol? I think that Pam has highlighted we've already reviewed this last time. I think Pam has highlighted the changes. We have adjusted the dosing to some of the pain medication.
So there's some hands up. Doug, and then Pesach.
Again, I think overall it's a great protocol. It's a great thing for patient care. I brought this up at last meeting. I just want to voice it. I do not believe that ketamine should be in this protocol. In order to give it the different routes, you have to mix it. It's only 5 to 10 minutes when you give IV or IO. It's very short acting. I think we're just complicating the care, by medics in the field by doing this for relatively short transport times. So just want to pass along, because you have to mix the medications, depends on route you give it. And I do not think pre-hospitally it's a good choice of pain medication.
Pesach?
Okay, hold on, Joe, I cannot see who's raising hands. I guess I'm not a host, so I'm going to let you do this.
Yeah, I'm holding that.
And also, that's fine. And also, everyone who is not talking, please mute yourself. We heard sirens in the background and all kinds of other things. Go ahead, Pesach.
Just a quick typo in the ketamine medical control option. The dose says 0.2 milligrams. I believe it's supposed to be per kilogram.
Exactly.
Okay, duly noted, and that will be changed. Thank you.
Okay, is anyone else raising their hand? Because I don't see any.
There are no other hands up right now.
I had my hand up. I'm sorry. It's Nick. How are you?
Okay.
I think I saw something on your picture. I was wondering what that was.
Yeah, it kept going on and off, so I don't know. Anyway, can I have a moment here?
Yeah, you have the floor.
Okay, so I just wanted to bring up my concerns again about the standing order of the opioids, morphine and fentanyl. I also want to express that I had some conversations with many members, many paramedic providers in my division, and many other seasoned and veteran paramedics regarding this discussion of having standing orders or medical control options. And I can tell you that overwhelmingly, everybody wanted it under medical control options. And I'm just here to advocate for those members that on the field level that have not been able to express themselves here in voting in this protocol. Many of the crews, many of the paramedics thought about it and think that there is a concern for their safety regarding having standing order opioids at their will. And it would be better controlled and better, it would be better for the agencies, for our service and everyone else to have these more controlled and managed under medical control options. So I wanted to voice that because I think the members in the field have not had the opportunity to be able to voice their opinion and their concerns, except for this matter.
Can I ask, what was the concern about having a standing order, you said, of having this in the field? What was that concern?
Well, there's a couple of concerns. One, that there's a safety issue, because the fact that the members or people out there will know that they carry pouches and they're able to administer medications at free will, and that there's a safety issue that they could be cornered anywhere, robbed or assaulted. The other thing was that they felt that they would be under stress and have to provide the medication without being, because they know that the protocol, and a lot of people would know that the protocol, they can't administer the medications. From a service point of view and from an agency point of view, it's going to create a problem during this opioid epidemic where people are going to be calling. We may be giving medications to the right people, and that's okay, and that's fine. But there are other seekers out there that we would be going around probably and giving medications. They would find out and they would be calling us and we'd be giving medications. And from an agency point of view, these patients can RMA, and our telemetry doctors are going to have to deal with this. And we're not able to monitor these patients on every protocol with medications. We monitor patients, but yet we're going to be expected at telemetry to take RMAs from patients that have been treated as long as they're lucid. So there's a lot of concerns here over standing orders. When it's a medical control option, the responsibility is taken off the shoulders of the paramedics, and it's allowed, it can be discussed with the physician on online medical control. And I think there can be a reasoning behind the appropriateness of the administration of the medication.
Okay.
I just want to voice that. I just want to voice that because the field medics are not comfortable with this, and we may be making this decision, but it's them who have to administer it.
Got it.
Yeah,
Hold on.
Okay.
Paul has
Hold
his
on,
hand
everyone.
up.
Whoa. Guys. One at a time, okay? I'm sorry, I don't
Paul
see
has
everyone.
his hand up, and I know that Dr. Krupe wants to talk, and I think you just raised his hand. So
I just want to read. I just want to read 2 messages from the text box. Kevin Ward writes, "We already have narcotics on our person in a pouch. It's been that way forever." Jason Zimmerman writes, "And there is already standing orders for isolated extremity. If the paramedic is concerned, they can always contact OLMC." So right now, let's let Paul talk. Go ahead.
Thank you, guys. I'm less worried about the specifics of the protocol, and I'm more worried about the precedent. And I'm not here to make anyone think the way I think. I think what makes us a great group is we have different opinions, and that's a power that we have here, is that we see things from different angles. So I'm glad that Nick feels and other people feel that this is an important piece to bring up. My caution is simply the umbrella piece here. And if something, what I don't understand is we have different agencies with different medical directors and different medicines that they carry. And as far as I can tell, and please correct me if I'm wrong, from my own knowledge, none of this says you have to give it. And I don't think that that's anywhere written. These are all if available. And if a provider doesn't want to give the medicine, that's their medical decision-making. And we support that. That's what a quality program is in place for. And I think that's something that as we go further into other protocols, we as a group need to come to an agreement that there can be differences in a protocol, but the protocol can't be essentially robot medicine on every patient. And if the paramedic is uncomfortable giving these medicines, Nick, then I think we should support them. I think we should support them and have them understand the medicines and how to give them safely or how to not give them if they don't want to. But I don't think any part of this says a paramedic has to give a medicine. I think it's up to them. I think it's their choice.
Hold on.
But understanding protocol, Paul, it doesn't say it just says that they can give it. So they can be forced into giving it because people will know that they are allowed to give it. Isolated extremity is isolated to an extremity. So it's a different protocol. It's not a general pain for anything protocol. That's all.
Okay. Bob Krupe, you wanted to speak, and then we'll go through the hands that are raised. So Bob Krupe next.
Yeah, just very quickly. I share all of Nick's concerns. write down the list of concerns that he brought up. I'll just throw something else out there. Okay, we know in the literature there's the issue of healthcare disparities as to who gets paid medication, who not, even in ED or in the inpatient setting. Some of these cross racial ethnic lines. Do we want to really put this on our paramedics without the involvement of medical control? I just put this out there.
So I will, just to clarify one thing, I don't mean to cut out a turn. The state's collaborative protocol has standing order opiates for pain management as a general pain management protocol. And again, I think that there's always a clinical decision making that goes into the field. I don't believe that if we change the protocol, the general public all of a sudden has an understanding of the protocols different than anybody else. I don't think that the guy who's shooting up on the street knows our protocols very well and is going to specifically call because of that. And providers, if they feel that that's the case, can either say no or can call medical control. You're next.
I agree with especially what you've just said. I'm sorry to disagree with Dr. Alexandru, but I also speak to medics in the street, and I never once had a medic express those concerns. The drug addicts out there know that the ambulances have controlled substance on it already for many, many years. In some agencies, they carry them on their person all the time. This is not an issue, not to any medic I've ever spoken to. And again, I want to reiterate what Dr. Schenker just said. The public out there doesn't know protocols. The drug addict who wants drugs. They don't know the difference between long bone extremities or other pain management. If they know you have it, they have it. And they also don't know the difference between medical control and not medical control. If they want the drug, they're going to call you, and you're going to go on a call, and then you're going to be having to call medical control, and they're going to want it anyway, and there's going to be an issue there. I really don't see this as an issue at all. I'm sorry. I think the protocol is fine as it is. And speaking as a medic, I have no issue with it at all.
Thank you. Morty Lax next. Morty Lax.
Yeah, hi. So I just, I'm probably echoing some of what people said here, but just really quick, like Dr. Schenker said, this is already in the state collaborative, and it's been done for over a year already at this point, or just about a year, maybe even longer. I think that it's a modern protocol. It's one that gives the medic options. You have ketorolac in there now, and I think that you're probably going to see, again, this is conjecture, but as a field medic as well, I think you're going to see that medics are going to go to that probably first in more cases than they were rushing to things like fentanyl or morphine in the past. That having been said, since it is in the state collaborative, if there is that much concern about it, perhaps a call upstate to get some data as to how it's been used until now and what the sentiment is up there would shed some light on what's going on up there.
Thank you.
And how the protocol works.
Paul, you raised your hand again. Paul?
I still think the piece about interpretation is unanswered. And I think as we move forward, regardless of how we feel about this protocol, so we all have differing opinions. And I think if we come to the conclusion that our protocols have to sit in the same Venn diagram for all 16 or all 30 of us, whatever the quorum is, that's not something that's achievable. And I think discourse is a sign of a strong organization. I think, academic and professional discourse is clearly relevant to a common goal. But if the protocol is written with various pieces that can serve the various agencies in our region, I mean, this is an enormous area, the most complex EMS system in the world. And it's not going to be as simple as it says it there. They're going to have to give it. And I think as we move forward, we have to come up with some agreeable plan where we can agree to disagree on certain things. Dr. Alexandru, in all defense, is never going to be okay with this. And Doug and Dr. Krupe as well. And there are other people who do see it a different way. And if we just bat each other's heads against the wall for 3 hours every month, it's not going to be anything productive. So we have to come to an agreement on agreeing to disagree and moving forward and finding common ground. because this protocol is just a microcosm of everything that's coming down. We're going to have the same problems as we move forward. And I think as an umbrella, we have to come to a plan. I'm sorry.
No, that's okay. There's 2 hands up, and then I think we unless there's something new that we haven't heard, I think we should kind of move along with the conversation. Matt Friedman and then Doug Isaacs, and then I think we can move to a vote. Matt Friedman.
So, yeah, I've got 2 points, guys. There really seems to be a clear lack of faith in agency medical directors to train their medics when they're using these opiates. You know, this is not for the benign abdominal pain. This is for the peritoneal abdominal pain. This is for the severe flank renal colic. This is a lack of understanding about who these patients are getting to it. And it's about training the paramedics. It's about building bonds with paramedics. It's about entrusting our paramedics. The fact that they're now have the option to give it as a standing order is going to all of a sudden make them to be, be able to get pulled over and commandeer their narcotics is a little bit absurd, I think. Second of all, those of us who actually treat drug seekers know that 5 milligrams of morphine does not do anything for a drug seeker's dependency. It really does not. I've never met a drug seeker in the last 5 years who 5 milligrams of morphine alleviates their suffering. So 1 dose of 5 milligrams of morphine is not, they're not going to be abusing our system more so than they already are. It's just not progressive to not incorporate these guidelines as they're written now.
Doug Isaacs, and then I think we're done with the comment.
Yeah, just because my name was brought up. I think most people know me. I'm pretty progressive when it comes to protocol and giving the tools for our EMS personnel to provide good care. However, I do have to speak up when we don't fully research something, asking someone their opinion as opposed to actually looking in the literature. There's a high expectations for physicians sit on this committee that we actually do literature research and looking at evidence-based medicine. And also I have to voice my concerns when I don't think something's appropriate to the field. I think we all have an obligation to do that. We all have opinion, but then we take a vote and we move forward. So I think we can certainly offer limitations, how much debate just to take up without taking up all this time. But, I think we all have a right to sit on this committee and voice our concerns when there's something to be brought up.
Okay, thank you, everyone. I think that everyone voiced their concerns.
Wait, David, I have one more thing to say. I'm sorry. I'm
sure. Go ahead.
Last thing is that I know you had said that the people don't know our protocols. That may not be correct. They know our protocols very well. All you have to do is ask an asthmatic how to call an ambulance to take an asthma treatment and then RMA. So they do get to know our protocols, and then sometimes they tell our members, "Go right ahead and call your doctor. I don't have to go to the hospital." So that's one thing. The other thing is just because the collaborative protocols of the state have this in there doesn't mean we're mimicking them. As a matter of fact, that's the whole idea of having unified protocols so that we can incorporate our differences from the state in this region. Otherwise, we should just join the collaborative protocols. So, and yes, you might be giving 5 milligrams of morphine and it's not a big deal, but that's going to happen every day by the same people who are abusing the system. And we're going to be running around giving medications to an opioid epidemic. That's it. Thank you.
Okay, very good. I think we heard opinions on both sides. I think that everyone voiced their concerns and their opinions, and I'd like to bring this now for vote. What we're going to do, the way we're going to vote this, Marie, for medical standards, I'm going to ask medical standards to put their vote in the chat box, and then we can count those. And if it passes medical standards, then we're going to do a roll call vote for REMAC.
Actually, can you ask Dr. Schenker set up polling?
I
No,
don't
it's not working.
control
It's not?
polling on my screen. Do you see it on yours, Marie?
Yeah.
Okay, so if you hit the polling button, you have to write the question. Just say yes or no, and then you can send that out to everybody. I just can't. I can't do it from my screen.
Okay. So
Brad
the motion
has to
is
repeat the motion. The motion is the protocol that is visible in front of you guys.
No,
As
it
written-
won't let me. It says my polling session is inactive.
All right, so
Okay,
we'll take that over for next time. But so what we'll do is for medical standards members, if you could just in the chat write agree or disagree or abstain, and then based on that vote, we will have a roll call vote for REMAC members.
Okay, so this This motion
Go ahead.
is,
To address Brad, it's the standing protocol that is on your screen right now, which is the general pain management adult and pediatric protocol. And it has 4 options: morphine, fentanyl, ketorolac, acetaminophen, and then 2 medical control options for morphine and fentanyl, and a option for ketamine, which has milligrams, which needs to be milligrams per kilogram. So you guys should be able to see that on your screen right now.
Okay, so I see people are starting to vote, and we are voting for the protocol as is submitted to medical standards. Okay, I'm going to vote too right now, and I think that Marie, from the text messaging and everywhere, people started voting after Brad's message about asking to repeat the motion.
I'm reading right now. So Lauren, this is as is on the screen. So it's including these controlled substances.
Thank you.
okay. Great. Okay, I am counting.
Direct message. You have to hit everyone.
So Marie, from what I see, there are 5 opposition votes so far. If that's the case, it would pass medical standards.
Okay, hold on, I'm just finishing. 1, 2, 3, 4, 5, 1 plus 1. 1, 2, 3, 4, 5, 6, 2. Okay, right now the vote is 11, 17 to 5. 17 in favor, 5 opposed.
Okay, if that's the case, Marie, if we can have a roll call vote of the REMAC physicians, that will take us through this, and we'll be able to move to the next item.
Okay. Let's get my voting sheet out here. Okay. So we are voting on pain management.
Protocol.
And that's with the one correction that's going to be made to fentanyl.
Just to the typographical correction where it's 0.2 milligrams per kilogram and not 0.2 milligrams. That's the only thing that's corrected.
Okay. Okay, so when I call your name, please respond in favor, opposed, or abstain. Robert Winchell.
In favor.
Joe, I'll save you for last, Dr. Schenker.
Thank you.
Nick Alexandru.
Opposed.
Kevin Munjal. Kevin Munjal.
Yes, in favor.
Cindy Basilios. Dario Gonzalez. Dr. Gonzalez. Glenn Aceda.
In favor.
Bradley Kaufman. Dr. Kaufman.
Aye, sorry, opposed.
I'm sorry, opposed?
Yes.
Dr. Kaufman, I did not hear your vote. I'm sorry.
He's opposed.
Opposed, okay. Doug Isaacs.
Opposed.
Nathan Reisman.
In favor.
Jeff Bradrich.
In favor.
Reed Caldwell.
In favor.
Lewis Marshall.
In favor.
Michael Redlener. Oh, not here. Wallace Carter.
In favor.
Peter Wire.
In favor.
Laura Ivacoli.
In favor.
Okay. Paul Barbara.
In favor. In favor.
Okay. David Benelli,
In favor.
Timothy Stiles,
In favor.
Mark Cantor,
In favor.
Joseph Bove,
In favor.
William Fisher,
In favor.
Robert Krupe,
Opposed?
Jessica Van Voorhees, Arthur Cooper.
In favor.
Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 17 in favor, 1, 2, 3, 4, 4 opposed. It carries.
Thank you. Okay, I'm going to stop
Okay,
sharing.
thank you.
We're back to Pam.
Good.
Congratulations.
Okay, Pam, so why don't we to the next call?
I'm sorry, I was talking on mute. I was just about to say, Joe, I think that you might have to share the vaccination administration protocol as well as the associated appendix that was also brought forth from protocol. So sorry about that. So I don't know if you know, Joe Schenker, if you would like to say something about this, but this is a protocol that. Oh, go ahead.
So let Doug share it or talk.
That's right, go ahead, Joe. You can take the lead if you like.
Okay, sure. So this was done. No, I just want. I mean, the credit for this goes to Doug and Yoni at the fire department for putting this together for us. Basically, this is a protocol that goes in line with what was discussed at the last Cmac meeting, allowing regions to develop vaccine protocols for the possibility of administering vaccines throughout the region. So basically, this is at the discretion of the agency medical director. This is a general protocol. This is not specific to COVID or flu or anything. It is a general protocol that is a one size fits all, so that we can then use this as a framework to put any vaccine that needs to be administered. I'm sorry, into this framework and use it as a guide. Assess the needs, screen for contraindications, provide information, administer the vaccine. There's a table here that suggests needle gauge and sizes based on patient's age and weight. And then the appendix, which is Appendix V, not on purpose, by the way, it just happens to be that was the next appendix that we were up to, is describe different vaccines. We have influenza as a template here, but if coronavirus vaccine were to be released, it's specific information about the vaccine and how it's packaged and so on to administer to patients. It's a relatively straightforward thing that gives us the opportunity to use it going forward. It is not specific to any one condition. We put influenza here as an example, but it really can be used as a template for anything. So I'd like to just open up for discussion. Anybody has any questions? All right, Doug, go ahead.
Thanks, Joe. Again, this is following the standard of care set by the CDC and other agencies. So this is nothing new that was brought up. And the federal government is, some people know, after H1N1, the federal government was putting forward the postal plan that I'm sure some of you know, allowing people from the post office to give vaccinations. So I think this is, given the current times we have, whether it's influenza or COVID or other things, to allow our medical professionals and EMS to also have the abilities within their scope of practice, which Joe mentioned, that Cmac state, it falls within the scope of practice, IM injections and so on. I think this is an important thing for our EMTs and paramedics.
Yeah, Doug, that
Joe,
is.
can I just raise my hand?
Yeah, go ahead, Glenn. I'm sorry.
Yeah, no, I'm sorry. Just interestingly, the state actually under declaration of health emergency by the governor, and then the state Department of Health actually does allow paramedics and CCs currently to administer vaccinations. And actually in 2009, I think it was either the Finger Lakes or Hudson Valley region actually did have their paramedics administer influenza vaccinations. But currently there are certain stipulations where it, under the state declaration of emergency, there has to be a training component, and they're also, they can only administer as part of a local or county Department of Health pod. So we were looking at this, and we have a biopod here at the fire department, and our Bureau of Health Services asked if our medics could administer vaccinations during this pod. And I told them that, we have to get this through the state and the region, because right now we usually rely on a temp agency for nurses. And it turns out that we have already been advised just for this influenza season, because their temporary nurses are being pulled to other parts of the country because they're going through a crisis now. They could not supply us with any nurses. So they wanted to try to have the paramedics. So obviously there's a lot of union issues, pay issues, and things like that. But again, from the medical piece, I reached out to the state, and that's when Ryan Greenberg said put something together. And then subsequently later, I found out that they had actually already done this. But I brought it to the state, kind of as a draft for discussion to see if they can allow us to, within an agency, provide this. And they wanted it very broad. They wanted paramedics, CCs, which we don't have in our jurisdiction here, and they ended up passing something that you may have seen from the state that actually kept it to local and county DOH pods. So that didn't help us. And they expanded the vaccination, allowing not only paramedics and CCs, but EMTs and CFRs as well. They also allowed during that conversation that all 4 levels of care would be able to swab test as well. So the thought was interesting, but not quite what we needed. And the state insists that swabbing for testing purposes is within the scope of practice of our EMS providers, which I can't remember in my EMT basic or my paramedic curriculum years ago ever being taught that. But anyway, so subsequently now the state is looking at trying to do a community paramedicine program that now would allow each agency to do it within their own agencies. And I said, well, we don't have at the FDNY a community paramedicine program. And the draft that they're putting together would now allow a vaccination program to be part of a temporary community paramedicine program that then would allow an agency to do it. So with this information, Doug went ahead and tried to put this into the protocol format. But there is also some discussion going on at the state. So I don't know if you guys have that information. I'm sure I don't sit on those committees. You may have more information than I do.
Yeah, so Cmac did, at the last meeting, did approve regions developing a protocol for this, which is where we're at right now. Anyone else? We did at the protocol committee, we did discuss, and I believe we seconded it coming forward to have it be for EMTs and paramedics. EMTs are trained in check and inject, so administering a vaccine is in the scope of what they're doing already. Any other discussion on this?
So, hey Joe, this is Kevin.
Hey Kevin.
I think this is great. I guess I think we should. I'm definitely going to vote in favor of this protocol. But I guess I'm curious exactly whether or not there needs to be a protocol, because this is something that is outside of. This wouldn't necessarily be in the setting of a 911 call, right? This is something that is potentially the agency might do internally or something else. And when we think about the interfacility work group that's being set up, I know there's a lot of maybe baggage there or history, but there's a lot of things that are done when they're outside of the written protocols that we have in the region, my understanding, and this is a probably important thing that we all kind of clarify, is that things that are not within the regional protocols, to the extent that things don't conflict with the regional protocols, that agencies have developed internal protocols and guidelines and things like that approved by their medical director. So I know a lot of interfacility agencies operate with that. They're doing things, vents, pumps, strips, all kinds of stuff that are not in our protocols. So at what, when does something like this need to go through a protocol? Nothing on
So at the Cmac,
this is controversial. I think it's all the standard of care. It's very responsible.
Right.
It's really good. But when would you need a protocol versus not need a protocol?
So I would say this, the examples you brought up of interfacility vents and drips and so on are all within the scope of a paramedic's training and are included in SCT or specialty care paramedic training, which needs to be done in order for agencies to have vents and have all those things. There has to be a training plan in place. The real question a lot of times with vaccinations is whether a vaccine is in the scope of a EMT or paramedic. And I think that was cleared up at the last Cmac, where they said that it is, assuming that a region has a protocol in place for it. So this is just a natural evolution of that decision at the Cmac level.
Okay. Any further discussion regarding this protocol?
This is Tim Strauss from the Health Department. Sorry.
Go ahead, Tim.
Just one comment here from the perspective of preparing for COVID-19 and considerations for vaccination. The locations that would be allowed to do that would all have to be have city immunization registry access and documentation, because that's how that's all going to be followed, especially given the vaccines that are going to be very specific and those that are going to have, it's going to be a 2-dose series. That would require everyone to be in the CIR so they can follow up within the next 2 to 3 weeks after their first dose and get properly administered. So, I like the concept of ensuring that paramedics are able to provide vaccine, but just trying to put it in perspective from actual distribution from the city's perspective, it's going to be a lot more complex.
Dr. Stiles, I completely agree. And you're raising operational concerns, which I don't think necessarily are the scope of this protocol right now, but they're definitely serious concerns, especially the fact that it's going to be 2 vaccinations. Any further discussion? Okay, hearing none, I think that we're going to do the same thing. We're going to do text voting in the chat box for medical standards, and then we're going to do a roll call for REMAC. Please notice that when you do the text voting, I texted Kevin Ward individually about my vote last time, so pay attention that you're texting to everyone. So let's start the voting right now.
Okay, I'm going into the chat now.
David, just to confirm, we're voting on both?
The appendix is an example specifically to influenza. If COVID were to become available as a vaccine, we would have to expand the appendix to include COVID, the information about tracking and so on, which would be added to the appendix. So the appendix is kind of a living and breathing document. The actual protocol is how a paramedic or an EMT would actually administer the vaccine, whatever vaccine that might be. So yes, in essence, we're approving both, but understand that Appendix V is a document that will flex based on what vaccines we need to incorporate into the region. And that'll all come to REMAC for approval at the time, but we're using this as a template to send up and approve.
Okay. Someone voted for Paul, apparently.
Yeah, how did that happen? No, seriously, I didn't write that. And it says from me. I mean, I want to take credit for all the things I do wrong. I don't know. Did someone write 4?
Paul, I see you voted in favor. From Paul Barber to everyone in favor.
Yes, I know. I still wrote.
Paul, you're on this chat twice. You're
How
on
did
the
that happen?
Zoom twice. I don't know. I have you here.
Come on, Paul. No double voting. You know, one vote a person.
I'm
One
gonna
of me
remove
is
you.
No mail-in
I'm
ballots,
removing
please.
you.
So
One
far,
of me
it's
is dead.
unanimous.
Count
One of
all
me
the
is
votes.
dead.
Unless he's
removed
voting
you.
for snake bites.
Okay,
Pull
so
one of
far
them
it's
off.
unanimous.
Snake bite jokes are no good. Come on.
There is
Okay,
no snake
so-
bites in this vaccine.
Hey,
Okay,
Joe, this is
so,
Cliff Styles again. Sorry.
Oh, there's one
And I
opposed.
apologize. I know you guys are already voting on this, but in looking again, I didn't have a good chance to look at some of these beforehand. Just to note, there's things like smallpox vaccine that are not intramuscular or intranasal. So if you're trying to cover every type of vaccine distribution, this isn't kind of it. So maybe it's a point that's moot, but
Yeah, hi, it's Doug. Yeah, so this is not meant to cover all vaccines. It's within the scope of practice of a paramedic or EMT, and that's why we're the CDC and also going through REMAC to approve the vaccine. So certainly within the scope of practice, and there was not an intention to make it across the board on everything. So
and I'll add on to what Doug just said. I think it will be impossible to cover everything, but at least the concept is out there.
Even though Kevin brought up a good point that we're not so sure that this required us to put something into play.
At Cmac, they did say that
They
you
would
need
like
to have
it.
regional version, a regional protocol. So they did ask that regions do this. Whether you needed to or not, I mean, this is an easy lift. It wasn't a complicated thing.
Okay,
Yedidia
everyone,
is
we have
commenting.
26
Yedidia
in
is
favor,
commenting.
1 opposed. So we can go. through
Yedidia
the
is commenting that it's totally irregular to discuss a vote that is already going on. I think that will. Yedidia has a comment, procedure comment that it's irregular to discuss a vote that is already going on. So I think we'll take Dr. Stiles' discussion before the REMAC voting.
What I would say is, so the vote passed medical standards. Is there any amendments that people want to make to the protocol as is? The protocol as is, again, just addresses IM and IN type of vaccines. It does not address something like smallpox, which would be a different type of vaccine. And to answer Kevin's question, we did report it. I think it was 2 meetings ago, because the last CMAC was so long ago. So
Yeah, and I believe there it was at CMAC, it was within the scope of practice. So, I don't think you have to say IN is whatever was within the scope of practice. That's the issue.
I hear you. I would love to have something to take to my lawyers.
We'll get it for you, Kevin. Okay, so is there any amendment? Anybody want to entertain a motion or make a motion to amend what we have right now prior to the REMAC vote? All right, hearing none. Marie, if we can do a roll call vote of REMAC physicians for this protocol and appendix, we can move forward.
Okay, for protocol and appendix.
Correct.
Okay, so as I call your name, in favor, oppose, or abstain? Robert Winchell. Robert Winchell. We'll go back to Dr. Winchell in a minute. Dr. Alexandru?
Yes.
Kevin Munjal?
Yes.
Cindy Basilios? Dario Gonzalez? Hold on, I'd like to see if I could unmute Dr. Gonzalez. I think he's having a hard time. I can't even find him. Here he is.
I'll undo them.
Okay.
Dario?
I think he's muted himself.
I think he's having trouble.
I did not, hello?
There you go.
All right, I didn't mute myself, all right? I know how to do that.
Okay. So
I've been sitting here sending emails, all right? I'm really getting a little pissed off. You make up a plan to do something when it doesn't work, you have no options. I vote yes in favor.
Thank you. Glenn Aceda,
In favor.
Bradley Kaufman,
In favor.
Doug Isaacs,
Favor.
Nathan Reisman,
In favor.
Jeffrey Rabrich,
In favor.
Reed Caldwell,
In favor.
Lewis Marshall,
In favor.
Michael Redlener, Wallace Carter,
In favor.
Laura Ivacoli,
I think she's.
She may be on the subway, in which case I'm her alternate, Kessler, and I'll vote in
She's
favor.
here. Laura
Okay.
she bounced out, but I just put her back in. So
well,
Laura
her alternate voted for her, so that's fine.
works.
Peter Wire,
In favor.
Paul Barbara,
In favor.
David Benelli,
In favor.
Timothy Stiles,
In favor.
Mark Cantor,
In favor.
Joseph Bove,
In favor.
William Fisher,
In favor.
Robert Krupe,
In favor.
Jessica Van Voorhees, Arthur Cooper.
In favor.
Okay, so 1, 2, 3, 4, 5, 6, 10, 12, 13. We have 21 in favor and none opposed. It carries.
Thank you. All right, David, back to you.
Okay, Pam, is there anything else from the protocol committee?
Yes,
You're
Dr.
muted,
Umack.
Pam.
You're muted,
Pam.
For REMAC from the protocol committee. Our next meeting is on November 20th at 10 a.m.
Okay, excellent. Is there any old business? I do not believe so, Marie, for medical standards?
No, there is not.
Okay, is there any new business? Is there anything that anyone wants to bring up for medical standards? Okay, having said that, I think, Joe, I will turn over the lead to you for REMAC discussions.
Okay, so we already did the correspondence report. As far as the minutes were sent out by Marie. I'd like to ask for approval of those minutes, or more specifically, does anybody oppose anything in the minutes? Please speak now. All right, hearing none, we'll take an approval of the minutes.
Motion to approve the minutes.
Thank you, Sean. Some subcommittee reports. The executive committee did not meet since our last meeting. The medical standards committee is jointly presenting data with this committee. So their report is inclusive in this meeting. The QA committee, the Dr. Redlener is not here. Joe, do you want to start and give that report, and I will fill in blanks?
Certainly, not a problem.
Thank you.
The Quality Assurance Committee met last week on November 4th via Zoom. So the topics of discussion is currently the committee has one regional restriction case that it is reviewing and is gathering data on that case. It is nearing completion of its COVID after action report with a series of recommendations that it plans to bring forward to the REMAC for additional planning purposes, as well as to the regional council. The First Watch stroke STEMI study is continuing to progress. Most 911 agencies are reporting data into the service. committee's currently working to finalize the dashboard data that will be available to the agencies that are on there, as well as to the region, and connecting in telemetry data into First Watch as well. The committee is continuing with its confidentiality agreement. It had updated it, and its members are completing those. The committee had a lengthy discussion in regards to how to manage and sort research project requests that are coming into the committee from outside entities wishing to utilize regional EMS data for various studies, and developing a more formalized process for evaluating those requests and how to present them to the REMAC for approval. So more information will be coming out on that. The next QA committee will be meeting on December 1st.
Any questions for Joe or for myself for the QA committee? All right, I see no hands up and there's no questions. We'll move on to training and education.
Hello. Just checking in.
Thank you.
Last thing, hold on, let me make sure.
Okay, Morty, the training and education.
Okay, so training and ed has not met since we last presented a REMAC. The BLS protocol update is up and it's running. There are over 600 people that have taken it so far. The ALS, for some reason, seems to have some sort of delay up at the Department of Health. The materials are up there. I know that you were in contact with Ryan, so that's being moved along, and hopefully that will be done within the coming day or so. So that's pretty much all I have for now. I'll continue to report on completion status, and we'll likely have to continue to aggressively message out to our providers and agencies.
Thank you. Any questions for Morty?
Hi, this is Brad. I just wanted to clarify and be sure that when we message, it's clear that anybody all the providers who have been trained in person do not need to do the online training.
Yeah,
that's creating some confusion.
Right.
We prefer to be trained in person, as many have, and so that's the preferable.
Yeah, I completely agree that the intent was for everybody outside of the fire department.
So
well,
yeah,
even,
I mean, again,
even
Brad,
people outside the fire department have been trained in person.
so
it's
I would
really-
say, I wouldn't listen. I would be very clear that anybody who's been through a training in person, and we should send this out to the region, does not need to do the online training. I do believe that either we need to provide a list to the state, or they need to do the 15-minute regional state bridge update thing. Which I guess if there's a concern on an agency level, you can discuss that with the state specifically. I wouldn't specifically call it preferred. I think it's there is benefits to it. There's also benefits to having an online process where people can get it done, and we can get it out to more people. So, but I definitely think we do need to send out a notice that if anybody's taken training already, they do not need to do it again. So that is correct. Okay. Any other comments or questions?
I had a question. How do you get a certificate if you don't do it online?
That's a good question. We were not set up for that. The understanding was that outside of the fire department, agencies were going to be asked to have this completed online. So those that have been doing it on their own, that wasn't the directive. If you read the advisory.
That's a problem, because I think some agencies that are not Fdny are in fact going to be doing training, and we have to figure out how to do that.
I would say that if you did train the trainer and you did the in-person training, you should provide a list of all people that went through your training to the region, and we'll submit that to the Department of Health.
Okay.
I think that's a fair way to do it, and that's what the fire department is doing for their members. They're keeping a running list of any of their members who been through training and are providing that to the Department of Health. So let's do that for now. If it has to change, we'll address it.
Okay.
Okay. Any other questions? Okay, I see none. I'm looking at the chat now or the I don't see any hands up. Okay, thank you. Anything else, Morty?
No, that's it.
Thank you very much. And the next meeting?
Next meeting is going to be within the first week or two of December.
Okay, great.
Don't have a
Thank
date
you
yet.
so much.
Yep.
All right, RTAC report. Is there anybody from RTAC here that would like to give a report? If not, I'll ask Doug to do it. Douglas, where are you? There you go. Can you speak to the last RTAC meeting?
I cannot speak to it, Joseph. I apologize.
Okay. There was some talk at the RTAC meeting to try to bridge the gap between the CDC's trauma triage criteria as well as the regional one, and also to evaluate protocols, in light of if a patient is in extremis or we don't use that word anymore, but is in cardiac arrest, should they be going to the closest trauma center rather than closest emergency room? I know that we've discussed in past the language of as long as they have an airway. If the airway is unmanageable, you go to the closest. But otherwise, the RTAC did suggest that it's possible that those patients are better off at trauma centers. I think the literature supports that. And also specifically for PEDS patients, that they be sent to PEDS trauma centers if it's within the 30 minutes that we've established. So that was discussed.
I think they wanted to go beyond that. But right now it's 30 minutes.
They do want to go beyond that, but they're willing to give a little bit on the 30 minutes, but they believe it should be 60. I think that if we can't give that to everybody and it throws the system off, it might be a problem though. But they are willing to concede to the 30, even though they would like the 60. You're correct, Glenn. Okay, that's all I can remember from that. We have this standing report from them. I wish we could get more representation from them to give their report in person. That would be helpful.
Joe, I apologize. Next time I will.
No, that's all right.
I do make all their meetings, so I apologize.
Thank you. Okay, the last subcommittee report is the ET3 tag, which met just before this medical standards meeting. Jeff, you want to give that report?
Sure. So the ET3 tag met, and really at this point, it's to address any issues that REMAC can help resolve for operationalizing the program. So a few issues that came up that the committee are working through is the QI of the data of ET3 once we go live that's going to be required. And I know we had previous discussions of a subcommittee of the REMAC QI committee to look at that. And I know Mike Redlander's not here tonight, but he had been working on that with the metrics that both CMS requires and that the REMAC are interested in looking at. So that's one issue that's being worked on. Another issue that came up is a patient information form, in that someone who has a visit and either the ET3, the EMS visit either becomes a ET3 telemedicine visit or a treat in place, where they're then going to be left. There was a lot of discussion about perhaps having a standardized form for the region that all agencies that participate leave the patient with kind of some basic information about, what do you do if you don't feel worse? What kind of, what just happened? You basically had a treat in place visit. So that's something that we're going to work on. And then hopefully that language, whatever we come up with, can be, vetted and approved by both the REMAC and all the agency councils that are involved, et cetera, so that we have a kind of a standardized information that we're providing to all the patients in the region that that have an ET3 type visit. And then the other question that came up, and unfortunately there wasn't anyone for the fire department was able to make that meeting today, but the issue of, as far as go live, the ET3 from CMS is can be started January 1, but not every agency is going to be ready on January 1. So the question is, does everyone wait and everyone starts on the same day? Can people start when they're ready to start? So that was a discussion item that came up as well. And then the final item we talked about was for agencies that don't have their own telehealth, Obviously, for the ET3 patient, we're going to try and direct them to whatever system they belong to. So if the patient is a Mount Sinai patient, they could be connected to that telehealth. If they're a New York Presbyterian patient, they could be directed there. But for those patients that have no prior established relationship with any system, how will we direct them regarding telehealth visits? So those were kind of the outstanding issues that came up on the call today. And we plan to meet every couple weeks or so before go live to try and make sure that we're facilitating whatever we can and that everyone's ready to go live and that the REMAC has what we need, in place.
Thank you. Grace, you have your hand up.
Yeah, in regards to the January 2021 initiation date, we will not have CAD ready on the fire department side. We're working on updating CAD now with the alternate destinations. That will probably not be ready to implement by January 2021.
Right. So there was some discussion, Grace, with that, is that for those agencies that are going to do telemedicine also, could one piece go without the other? My inclination is probably not, but there was some discussion around that as well.
Right. And if
Well, I think that's I'm sorry, Grace, go ahead.
If I understood correctly from Dr. Prezant, if the patient didn't belong to any specific hospital family, it would go to H&H.
Right. We just wanted to confirm that. So if an agency that's participating doesn't have their own telehealth, they can use H&H.
Correct. And were you on the call on Friday? We had an internal call with the fire department on Friday with General Devices and how we would utilize them as the main hub.
No, but I think some of the people were on that. Some of the participating agencies were on that call.
What I think is happening is that there's a lot of different ET3 conversations going on, and we probably need to have a central discussion at some point, because let's face it, this is a 911 operational project. We all agree with that, but there's a lot of pieces of the region that need to go along with it in terms of protocols, in terms of getting alternative destinations into the NEMSIS database and so on. So I think it might be helpful if we can get everybody in one place or on one call so that we're all on the same page and we're not having three different groups, everybody deciding their own, having their own discussion.
Right.
So
It's definitely
I think
operational.
definitely streamlining this information is going to be a key if we want to be doing this well.
Right. And how we can support that, just so that, at the REMAC end, we're answering the questions appropriately.
Okay, so I think that should be going forward, maybe between Grace, Doug, and Jeff and Marie, we can get everybody that needs to be on a global call together and take this forward to make sure everybody's on the same page. I think that's a really important part of this because there's so many different moving parts.
Do we know who was invited from the FDNY to today's meeting? Because it doesn't appear like any of us were aware of it.
I think Dr. Prezant was on the email. I don't know who else.
Yeah, definitely Dr. Prezant was on the email. I can't remember who else was on there.
Again, I don't want to reinvent things that are going on already, Grace.
We just want to help.
It's important that if the fire department has having a meeting about this, we don't need to have a separate meeting running in parallel. We need to have one so that everybody's on the same page and everybody knows what they need to do. So if REMAC can assist with developing this program, we need to be there to do that. But we only know that if we're all talking the same language and on the same communication stream.
Right.
So
we don't want multiple
that's the
committees.
key.
We just want to be able to assist and have the right information.
And just so you're aware, the fire department is having a meeting with the voluntary hospital sector sometime next week. And we actually asked to have a portion of that meeting for ET3 to address what the needs of the voluntary sector are. So there is another upcoming meeting that we are planning to attend. And once we have everything under order, I plan to have a workshop with the voluntaries to ensure all our EPCR data is somewhat identical. So it'll be easy to query reports for us to provide the metrics needed for the whole ET3 project.
Well, again, so Grace, that specifically is the quality component is a REMAC, component that we really want to make sure that whatever metrics we're monitoring are funneled to the right QA group. So that definitely has to be discussed. And the other component that was brought up on this earlier call was training of paramedics in the region. And we have the Training and Education Committee, which has been putting this together and using the LMS to get this information out. We all should be on the same page with that as well. I don't want the
EMS meeting.
Different paths.
Oh, it's Allison and Grace. I've been emailing with Harold and others at Fdny about next week's meeting, which is a quarterly meeting that we haven't had thanks to COVID for a long time. But the folks on next week's call are really not the right audience for the ET3 conversations. I think we are all collectively, fire department and agencies that were awarded to participate in the pilot, trying at this point to meet extremely aggressive deadlines.
You're not talking. Please mute your phones.
Sorry.
You're talking, Allison.
Listening to another meeting.
Yeah, James, you're muted. Can you mute yourself, please? Thank you. I just did it.
I think when we talk about, operationalizing implementation protocols, when we're past just getting the ink dried on what we need to get down to CMMI, I think we should definitely all get aligned so we're not stepping on toes and creating parallel or redundant efforts in this work in the region. But next week's thing, I don't think is the right audience, and I've said that to the folks at Fdny.
All right, I think that we'll have a small group get together to figure out who has to host and how we can have a conversation between the fire department, voluntary hospitals, REMAC, and other agencies, including alternative destination, representation, to make sure that we're all on the same page as to what needs to happen from a regional perspective.
Agreed.
That we'll move that to offline and get that done. Okay. Any other questions about the ET3 stuff? Yeah, Robert, go ahead. You're muted. So you got to unmute yourself first.
Hey, thanks a lot. Have we looked at care protocols that the physicians who are providing the guidance to the EMTs are using, or are we just going to make up our own as we go along? Is there standardization on the kind of care we're going to be giving?
Protocols that were developed, and they're not directing the EMTs. They're either providing telehealth services or directing the EMT to go to an alternative destination. But I think we'll take that offline, because that was stuff that we spent a lot of time on last year and went up to the state and was approved.
Right. And this committee, so as far as the actual telehealth call, we don't direct physicians how to provide telehealth.
All right.
Thank you.
Okay, no problem. All right. So I think that we have a little bit of communications to do and to get everybody on the same page, and that'll be the next step. I'm sorry. Anything else? Anyone else? Okay, seeing none. Your regional council update.
Okay, I'll make it quick. REMSCO met October 27th, 2020. There was discussion regarding how to proceed for the Glen Oaks VAC expansion. The public hearing has already occurred, but I don't believe we've heard back from the public hearing officer yet. There is an ambulance agency mapping project, which you may be aware of, and it is nearing completion. Benson VAC is receiving technical assistance from the volunteer districts, but they're required to reach out in order to get that help. There's a mental health team that has begun its training from the New York OMH. Regional council and program agencies are still being processed, which means we don't have our contracts. and a letter requesting a commitment from New York State DOH will be written or has been written, Marie. I don't know if it's already been done. There was a briefing on the HealthX data sharing program. And finally, it was announced that New York State DOH is no longer accepting paper PCRs. If any of your agencies are still using paper PCRs, stop. Agencies have to scan and do manual data input if they're not going to electronic stuff. And there is a tag working on this with possible funding opportunities to help you move from paper to electronic. And the next meeting is next week, same time, same place, next week.
Thank you. Any questions for you, did you? Paul, you raised your hand.
Hey, thank you, Joe. Dr. Langston, quick question came up at my facility. I'm sure it comes up at all of yours. The lack of transmission of, if the state is making a motion that paper PCRs are no longer acceptable, I think we all recognize there's a lack of transmission of health information when it comes to the logistics of the ePCR system. And without turning this into a very long conversation, it's sometimes days before the ePCR is actually written, signed off, and uploaded and transferred to the hospital. This leads to some legal issues. And I was actually tasked with this at my facility to identify what the standard of care is and what the expectation is. And my question essentially is, does the state have any expectation for the transmission of ePCRs as part of a healthcare record that the physicians and clinical staff who are taking care of the patient at destination are expected to receive and make use of? And if not, should we as a region have an understanding that this system that's a state mandate essentially does not work, and we're actually putting our hospital providers at risk because of lack of transmission of information, and start taking the EMS documentation and much like a clinic note or an urgent care note, as opposed to what we grew up with a piece of paper being handed off at time of disposition? Thank you.
So I can tell you, I understand that the state is aware of this issue, but as usual, they don't have a solution. Upstate, where things are less complex than New York City, it seems to be working somewhat better. I'm not confident that New York City is going to get its act together, because this is a horrible IT problem going across all hospitals and all agencies, and I don't know exactly how to do it. If I could sort of be whimsical, in Israel, every ambulance has a little printer on it. They do use ePCRs for years and years and years, but they have a little printer on every ambulance. And what they do is they print up both a patient bill and a PCR, hand it to the patient as they get off the ambulance, and hand the paper to the hospital. Well, I don't know the solution, but you're raising a very important problem. I don't know.
Just make a statement. Joe Ranieri from our office is working, I believe, with QA on some project to join data. I can't explain it that well. I don't know, Joe, if you want to say anything about it.
Joe and
Marie, that's something that's going to take a long time to get into place. That's not an immediate solution.
Yeah, Kevin Munjal and Joe are both on the call, and I've been on a number of calls, and there's a lot of activity around finding a standardized way, recognizing that all of the EMS providers use different vendors, and although the data elements are consistent because we all comply with that, that we just need to make it interoperable. And I agree, Kevin and Joe are the brain trust for the reason behind this. But I think it's on a shorter track than people would think. I don't know if Joe or Kevin comment.
So, well, Joe, do you want to speak to that?
Sure. So we have a committee that is working right now on solving this exact issue with transferring of data and realizing what everybody kind of envisioned when ePCR started, the free flow of data from EMS into the hospital EMR, and then also eventually getting outcome data back into EMS. So We are working very closely with the New York City RIO, which is Healthix, and having discussions with State Department of Health and a wide range of stakeholders on how to make this happen and make it happen soon. We are working out some specifics on getting some pilot work going to show that we can get the data flowing, get it into the hospital EMR, and show that it will work well, not just for hospitals seeing a PDF of a PCR, but even doing more than that. So that is what the committee is working on. I don't want to take too much time out of the meeting for it, but there is a lot of stakeholders that are working on that and getting that to be realized.
Great, thank you. All right, so there's a few hands up. I know that Robert, you had your hand up in person, so let's go with you first, and then I'll go through the people that have their hand up in the room or digitally.
Thanks, Joe. Paul, it's a great comment. We're also struggling with getting the EPCRs into our electronic record. And so the question I have is, have we done a needs assessment of the community to find out why we can't get these records done in a timely manner? Have we asked that question? Have we done a survey? That's question one. Question two is, what would be the possibility to, Allison, this is to you, for us to put together like a district-like program for our EMS providers? If you recall, when we first started district, we had to go to all of the community healthcare providers to find out what EHRs they had and what they were capable of. Perhaps we can go to CMS, CMII to look at a promoting interoperability program for our EMS providers. That's it. Thank you.
Thank you. All right,
Dr. Leviton, thank you for that comment. I just want to respond really quickly.
Sure.
Disrupt was a very timely thing, and hopefully some of the successes realized we get to implement with the new administration coming in. But I will say, quite frankly, health information exchange is beyond a decade long. It's like a bear. We've not been able to do this since the first HEAL grant, which we thought was a lot of money a decade ago, and it was, in the tens of millions. We've not gotten good at health information exchange yet. We're getting better, and I think the vendors are getting better at meeting their customers' needs. And hopefully we can do this in a shorter time frame than everything else we've been working on for decades.
Thank you.
I'll give you a call during the week. Thank you.
All right, Ben Zabar, you're next, and then we'll go down the list here.
Yeah, just two things. One is, I don't know where it came from. I mean, I've heard that the state gives you up to 24 hours to leave an EPCR, but I just found a policy statement from the state, which I just put in the chat. And it talks about electronic PCR data submission, but in it, it basically says you're required to leave at least the basic information of the treatment and what have you before you leave the hospital, like after you drop the patient off before you leave. So I don't know if that's been superseded by something else because it's from 2012.
Nope,
but
that's
that
a standing rule from the state. You're supposed to leave that information before you leave the hospital.
You cannot leave the hospital until they have the information, whether it's a fax or something else.
Right. No, I agree. So to Paul's point, where he's saying that he's having cases where, crews are not, that it's not getting into the hospital for 24 hours. That seems like that's not in compliance with the state's regulations, or at least what I'm finding.
Okay, thank you.
Yeah, that's not happening.
Pesach.
Yeah. Hey, sorry, my battery was dying.
Sorry, Joe.
Are you calling on me?
Well, Pesach, you're next, and then I think Brad wants to say something, but Pesach, you're next.
Yeah, sorry about that. I just had to plug in. I wanted to say basically the same thing that Ben just said. He brought up the policy from the state. There's also the DOH 5136 that every agency has to sign when they transition to EPCR, which, to quote, says, when transferring the patient to the care of the hospital, the EMS crew must provide the receiving hospital with both verbal and written reports at the time of patient transfer. And then there's a section in there where you have to fill out how you are going to make sure to implement that in your agency. And that's something that everyone who's using ePCR, I believe, has signed. So to answer what Paul was asking, what the standard is, that should be the standard that everyone agreed to, notwithstanding the fact that there are compliance issues and it's hard to implement.
Okay, thank you. Laura, you
I
had
don't
your
wanna
hand up
take
and then it went down. I don't know if you
away
had
from that. I
someone to
know
say
that that
something.
is an issue, but I think this is what we should be, the goal should be to
meet the standards. Got
Hey,
it.
Joe?
All right, Brad, yeah, go ahead.
I'm sorry, just so you know, some Zoom like mine, we don't have the raise hand feature, just so you know. Not everybody has
Okay,
that.
well, then just raise your hand on the screen. I'll
Yeah, I
call
can
on
try.
you.
So
Just keep
absolutely.
jazz hands.
Patient care is key. The doctors and the providers in the ER have to see what the EMS did. I test my ER on this all the time. When a crew comes in, I make them get that PCR. If they can't, you have to contact the agency. This was a state rule when I was on the Cmac. It's not electronically in the record, but they have to have it. If an agency does not leave either a faxed or a copy before they leave, you need to let that agency know that they're in violation. This is patient care at its most basic form.
Thank you. All right, Laura.
Yeah, the only thing I was going to mention was that I think Kevin might be on, but we've worked very closely with Mount Sinai because they do have a way of using Care Everywhere to get the ePCR into their medical record, and they're now trying to work with the Rio, but we've been trying to do this for, oh gosh, I feel like it's been a couple of years now trying to make this happen with Exchange ER. But it's a big problem because we definitely get ePCRs sometimes more than 24 hours after the patient has been dropped off. And it's, vital information to taking care of the patient.
All right, thank you, Laura. All right, Paul,
Laura, this is Robert.
Robert, hold on. I got you. I saw you. Just let Paul go next because he's been waiting a while.
I would challenge each of you who are a medical director to look in your agency and see 100% compliance on ePCR documentation. And if so, please tell me how you're doing it because I'd like to know. And secondly, I would challenge you to look through your EDs and see how many patients are brought in where you're getting an ePCR the same day. And again, show me your numbers and I'll be glad to work and learn from you. All I'm saying is this is a pervasive problem with a lot of high money fixes. I think the evolution of EMS care in our region, in our nation, no one's questioning an urgent care note. No one's questioning a primary doctor's note. We're working with information that's limited. I don't think it's unreasonable for the REMAC to have a stance on a failed transmission and the expectation that the provider has to make from that. Because in a legal situation, it's expected that that information has been transmitted. But the provider and the hospital are not at fault for failed transmission of information. And we all know this is a decade old and it's not gotten better despite LTE, Wi-Fi, taking all the other broadbands that it's reserved for emergency responders that Verizon puts commercials up about. It does not work. The providers are not writing the notes. They're not writing them in real time. We have people reminding people to write their notes, just like we don't write our notes all the time. And I think a stance on the lack of transmission is what I'm looking for. I don't want to belabor the point, though.
I think it's a good point, Paul, and we should go back to venomous snake bites.
That's not even funny anymore. That's not even funny anymore. Come on.
Come on.
Hey, you guys can get a new joke for Christ's sakes.
Yeah, please cut it with the snake bite jokes. It's old and it's rude. Thanks.
So Joe, the question then becomes to respond to Paul's very passionate comment, and I agree with you wholeheartedly. If I've got an agency because they have not provided us with an ACR or PCR, should I be copying Marie? Should I be copying someone at REMSCO so they know that this is going on and we can keep track of those contacts? Maybe we can start by doing something simple as I write a letter, I copy you folks, and you folks say, wow, this is a pattern, this is a trend. That's number one. For those of you who are using Exchanger, we now have a program where we're importing Exchanger in real time into our EHR. We're using Epic like a lot of your folks here. So if you'd like, I can share that policy with you and how we're doing that. We've been working with the Health EMS folks, and we're getting a pretty good, almost instantaneous download of an imported document from Exchanger into the Epic EHR. I know the other EHRs can do this as well, so maybe we want to look at that as well as a solution.
Okay, thank you. Grace, you had your hand up. I'm sorry.
Yeah, I'm in no way making excuses for our crews. Exchange ER is your best bet. You're getting that information real time. Once the crew goes 82 to a hospital, that information is already preliminary coming across your screens. The problem is we have numerous hospitals who subscribe to it but don't utilize it. And
Correct.
just an example, and I won't give the hospital, a hospital reached out to me last week that wasn't receiving EPCRs for 36 days. It took them 36 days to realize their fax machine was not working. So we can't put the blame on this on solely EMS crews. The fax machines are obsolete. They really should consider utilizing Exchange ER so everything is digital.
But this, to piggyback on that, what we're finding, and this goes back to the interfacility transfer program that's before, those interfacility transfers that we're seeing are not in Exchanger, and I can't get a hold of those EPCRs. So there's another issue when we get back to the interfacility discussion that was started at the beginning of this meeting, that we want to make sure that those agencies are either using Exchanger or are getting us the EPCRs as well.
In order for Exchange ER to work, though, they have to be utilizing the Stryker Health EMS application. If they're not utilizing those EPCRs, the EPCR is not going to come over Exchange ER. So if you're utilizing Zoll or any other application, it's not going to come over Exchange ER.
Morty
We're aware. Thank you.
Yeah, most interfacility agencies are not using, virtually no interfacility agencies are using Stryker's PCR solution. So really the only true solution to this is once the project that Joe Ranieri and Dr. Manjala are working on goes through. That's really the ultimate solution. We really all need to do what we can to support that.
Okay, thank you. This is a very obviously heated discussion, and everybody feels very passionately about getting the information about healthcare because that's what we're here to do. I agree with it. I think that this is a very important issue. I know that Exchange ER has a lot of that information for the 911 system for people that are using Stryker. Other agencies should be sending the data via fax or whatever the system that they're using. I don't think that to send to the region every time somebody doesn't do this is the right process. But if you're seeing a pattern, if you could let us know, we can address that with the agency specifically. So if you're seeing a pattern with a particular agency, not a case by case, but if you have 10 calls from agency X, maybe we can address that with agency X and see what their issue is. But that's a great discussion, and I'm glad we had it. Thank you, everybody. Next would be the Cmac update. Lou, I don't think there's been a Cmac meeting, but anything you want to add?
No, nothing. The next meeting is scheduled for December.
Great, thank you. All right, any unfinished business that I don't remember? The only thing that I have left is the bylaws. We are at the third reading of the bylaws. And then if there are no changes, we can vote. I'm going to put up the bylaws, and then I want to bring up a discussion that I had via email with Paul. I don't know if he's still here. Or, I'm sorry, Peter. So no, this is not.
I'm here, but I don't think you want me.
Let me just share the right document because I have the wrong one up. Okay, and here we go. All right, so Peter wrote a very eloquent email to me that I want to bring up for discussion. The Medical Society of the State of New York is a group of physicians that has a seat on the REMAC. this language for non-EM physician was added in this bylaws revision because, and the reason behind it, by the way, just so everybody understands, is that there are many agencies, many societies that have representation in our region. And this was a way to ensure that physicians that are not the EM physicians, not the physicians working on the front line, are also involved with the discussion. And hopefully the medical society would want somebody who's not a frontline person to be involved. Peter, I'm going to let you, if you want to bring up your points. I know it was very well written. I just haven't had a chance to share with the group.
Right.
If you feel that, I mean, I'd like for you to share what you mentioned to me, because I think that's important.
Right. Well, yeah, I mean, I think the issue here is it's one of form versus process. There are a number of emergency physicians who are very active in the medical society, but there are very few people outside of the emergency community in the medical society who would be motivated to put in the time and take an active role in REMAC. When I joined REMAC, that was actually almost a quarter century ago. I replaced and I've always my presence has always been as the representative of the first district branch, which are the 5 counties of the medical society, the 5 boroughs. And my predecessor was someone who had never attended a single meeting and who had no interest whatsoever in REMAC or EMS, no involvement in any aspect of emergency care. He was not an emergency physician. I think he was an invasive cardiologist or something. And that had been the case for years. So all I would say here is that if you want someone, I understand and agree with the principle here, but if you want someone who's going to be an active part,
I'll be right back. I'm gonna go over to Peter's.
I would not exclude emergency physicians. I would actually, there are other advantages to having a liaison between REMAC and the medical society. And I think if you want an active liaison, you need you're probably going to wind up with someone who is an emergency physician.
Right. No, I understand the point, Peter. I think the thought is that there are a lot of other groups. There's the New York ACEP, there's New York NAMSP, all of which are EM groups that are not specifically in our region. And if the medical society specifically, if we're giving them a seat, you know, there are so many emergency physicians on the committee already in terms of seats and positions that having a non-EM view would be beneficial. I also want to address while we have this conversation here, Robert, we discussed this at the last meeting, and it was felt that there's enough representation in the people on the committee to meet that need. But thank you for bringing it up again. So again, I think that, did you correct me if I'm wrong, if we do make a change and remove this non-EM physician, we would have to begin the process over again? I'm not sure.
Yes, you would. You would have to start it again. It would go another 3 meetings. And remember, you need a 2/3 vote to change a bylaws, a final 2/3 vote. So keep that in mind when you're voting.
I think that, I mean, again, I think, Peter, I think it's a very good point. I just think that I'm sorry, Ben, I know your hand was up. I'll call you in a second. I think that the purpose was to have somebody specifically who is not an emergency medicine physician to have a different perspective. And that might make it harder to get that person on the call, but I'm hoping that there's somebody who's not in the EM world that is interested in what we do. I hope, at least. Okay, that said, Ben, you had a question?
Well, I was just curious if medical standards has a separate bylaws, or if that's, because I know it's a subcommittee sort of at the REMAC. Or
Medical standards is a subcommittee of REMAC. They have, they do not have, I'm not sure that they have specific bylaws. Marie, you want to answer that?
I was just curious about the membership
they
because I know
do.
we're talking about changing the membership of the REMAC and how that would affect the membership of medical standards. I'm just curious.
Medical standards is compiled of EMTs and paramedics and medical directors from every agency in the region. So every agency medical director de facto has a seat on medical standards. This is specific to these positions.
Okay.
Yeah, and medical standards is not a statutory committee, so
Right.
this is the committee that we really have to deal with.
Okay, so I mean, I know there's a lot of bylaws committee members on this call. Does anybody feel strongly about changing that language? I think that we did think about it specifically when we put it this way, but I wanted Peter's comments to be heard because he definitely made a valid point.
FYI, Joe, I don't know if it's just me, but I'm just seeing a black screen on your when you're sharing.
I'm sorry. Does anybody see the bylaws?
Yes.
Yes.
Okay.
Yes.
So that was you, Kevin. Okay. All right. Well, so I'm going to go through this one more time. I think that I haven't heard from any of the bylaws committee members, so I'm going to leave it as is. I'm going to go through the bylaws, and then if there are no questions, I'm sorry, Lou, go ahead.
No comment. Sorry.
So I'm going to go through these bylaws. If there are no comments in addition, after I'm done going through them, we will have a roll call vote on the bylaws. Paul, Barbara. Okay. Yes. I think that Paul's comments are just generalized, but thank you. I think those are valid points, Paul. Okay. So these bylaws are set by statute, Article 30 of the Public Health Law, representative organizations within the emergency medical services system of the city of New York. The purpose, coordinate, develop regional medical control system, develop regional standards of care, develop and approve treatment, triage, and transport protocols, quality improvement activities, and to approve training sites, course curriculum, and certification standards. 42 members of REMAC. Let me make sure that's correct. Marie, that number has to be changed. That should be 45, actually. That's the number when you do the count. There are 45 members, and this is the breakdown. So the fire department seats will increase. They'll have 7 physician seats, 1 non-physician designee, and 2 emergency medical technician paramedic seats. Greater New York Hospital Association will have 4 physician seats, 1 emergency physician, 1 ambulance service medical director, 2 online medical control physicians, and 2 EMT paramedics. The Downstate New York Ambulance Association, formerly known as Onion, would have 1 ambulance medical director seat and 2 EMT, either EMT or paramedic seats. The Volunteer Ambulance and Rescue Association would have 1 medical director seat. I'm specifically focusing on the physician seats just so we're all on board with that. There's 2 emergency medical technician seats, trauma surgeon from a regional trauma center, a pediatric trauma surgeon, a burn surgeon, police department physician, a health and hospitals physician, and a REMAC regional EMS council physician who can be a chair or a designee of the chair. The DOH MH will have 1 physician seat, and then there are community seats. There's 2 EMS medical directors, 2 nurses, or I'm sorry, 2 ED medical directors, and 2 emergency department administrators / physicians, 1 psychiatric emergency physician, 1 pediatric emergency physician, 2 paramedic program medical directors, 1 from the municipal sector, 1 from the non-municipal sector, and from the Medical Standards Committee, a chair and a vice chair, 1 from the municipal sector, 1 from the non-municipal sector. The Medical Society of the State of New York is a non-EM physician, and then 2 non-voting seats. The total count is 31 physicians, 14 non-physicians, for a total of 45. Widest possible distribution. Therefore, your primary affiliation must be with the organization that you are appointed by. Terms of appointment is 2 years. You may succeed yourself. The appointment process. From a constituent organization, it's a appointment from that that organization to REMAC, which then gets forwarded to REMSCO for approval. At-large seats go to a REMAC nominating committee and then to REMSCO for approval. Each constituent organization must define the process by which a member will be nominated to REMAC. Online medical control physicians are credentialed by REMAC in compliance with Part 80 of the Public Health Code and are actively providing online medical control. EMS community seats, REMAC seeks nominations from the EM community as a whole and emergency medical organizations, including all those that I mentioned previously. Trauma surgeon, pediatric trauma surgeon, we will seek nominations from the RTAC. Burn surgeon, it will be candidates from regional burn centers. Psychiatric emergency physician, candidates from regional psychiatric facilities. And pediatric emergency medicine physician will be also from the community, from pediatric emergency physicians in the community. New York Department of Health and Mental Hygiene is a nomination from the Commissioner of Health for the City of New York, and emergency management is from the Commissioner of Emergency Management. That's a non-voting seat. This is important. I want everybody to hear this.
Joe, I'm sorry, can I interrupt if you go back to the
Sure.
pediatric area, because that is something that I think we should all be cognizant of.
I'm sorry, go back to what?
The psychiatric.
Yes.
Okay. It's something we should all be thinking about based on really what everybody's dealing with, in particular, our own workforce. And how do we integrate that? And I'm not sure we have representation from that. If there is an opportunity to put people forward, I'd love to talk with folks about willing volunteers.
So we tried to leave this a little bit broad, but yes, any physician who is providing psychiatric services to our providers would definitely fit the purpose of this seat, and can be submitted for nomination to the REMAC. So if you have any physicians that are doing that, I think that that's a great idea and it should be appointed, but I don't think it changes the language of the bylaws for right now.
Okay.
Okay, so removal of membership. I wanted everybody to hear this because this is important. Once seated, a representative may be removed by the nominating constituent organization or a 2/3 written vote of the entire membership of REMAC. Important, members with more than 3 absences from regular meetings each REMAC year shall be considered to have voluntarily resigned and will be notified in writing thereof. This is not 3 in a row. This is 3 over the course of the year. Considering that we have 6 meetings a year, it is important that you make it. Absences for which members are represented by their designated alternates shall not be counted as an absence. So if you have an alternate, they can sit for you. Vacancies shall be filled as soon as possible in accordance with the process described above to complete the unexpired portion of the term. Alternates, designated alternates for each member are permissible provided they are duly nominated by the constituent organization involved. This, Glenn, if you're still here, this includes the fellows being alternates for the FDNY medical directors.
Okay, thank you.
REMAC shall not meet fewer than 6 times per year. The calendar will be distributed. Only physicians are eligible to vote. All issues shall be decided by a majority, which is 16 out of 31 of the total voting membership at REMAC, whether seated or not. You need a majority of the total voting members to pass something at a meeting. A quorum.
Joe, doesn't have to get updated. You said it's
Yes.
45 now.
There's not 30.
No, the 31 physicians. 45 is the
okay.
total number.
Gotcha.
But the 31 is the physician number. The only number that wasn't updated was the total seated members, and we're talking about voting when we're talking about conducting business. A quorum is 50% plus 1 of the voting members. So for 31, it's an odd number. It's 16. Whether seated or not, all final actions shall be by means of a roll call vote. The chair shall be empowered to allow for a recorded electronic ballot in the event that a quorum cannot be achieved for 2 successive meetings when so directed by the membership of REMAC. Officers, a chair, a first vice chair, and a second vice chair. The chair and vice chair shall be physicians. All three can be physicians, but the chair and the chair and the vice chairs will be physicians. All officers shall serve for 2 years. They may participate in all debates, and they can cast a vote in the event of a tie. The chair shall preside at all meetings, have the right to convene emergency meetings as necessary. A vice chair shall assume the responsibilities of the chair in the absence of the chair. Sorry, I have to breathe. The REMAC shall recommend to the REMSCO 2 physicians, 1 FDNY and 1 non-FDNY, to serve on the State Medical Advisory Committee and recommend nominations to the Commissioner of Health of the State of New York. The chair shall appoint a member to act as parliamentarian for the REMAC. All meetings shall adhere to and follow Robert's Rules of Order, latest edition, unless contradicted by the New York State Open Meeting Law and General Construction Law of New York State. REMAC shall establish an executive committee of its elected officers. REMAC shall establish advisory committees that focus on medical control issues related to advanced and basic life support, which is the Medical Standards Committee. A joint quality assurance, quality improvement committee in conjunction with the REMSCO, and the standing committees shall develop their own bylaws and submit the bylaws to REMAC for approval. The chair, with the approval of the REMAC, shall establish a nominating committee for officers biennially. The chair, with the approval of REMAC, shall establish ad hoc committees as needed. The chair, with the approval of REMAC, shall prospectively define the scope of activity and duration of service of all ad hoc committees. Representation on REMAC committees shall be inclusive of all pre-hospital sectors as appropriate. These bylaws may be amended only if proposed amendments have aged between a minimum of 2 consecutive REMAC meetings and then by a 2/3 vote of the members of REMAC. Okay, REMAC decisions on medical matters made by REMAC will be sent to REMSCO for advice and comment and for informational purposes only. REMAC shall report to the State Medical Advisory Committee as required by statute. If any of these bylaws are in conflict with statute, the statute shall prevail. If any parts of these bylaws is judged invalid by a court of competent jurisdiction, the judgment shall not invalidate the remainder thereof. And that, my friends, is the bylaws of REMAC. Does anybody have any questions? Okay, hearing none. Marie, if you could have a roll call vote. I'm sorry, Brad, you had a question.
Just the date on top. We have January.
Oh yes, Marie, that date has to be revised to now actually, because once this is still the draft, Brad, but once these get approved, it'll be revised to today or to.
They'll be redated the date that we're approving them.
Correct. Okay, so we're any other questions? I'm looking for hands. I'm looking up and down and
I have a
left and
question.
right. Yeah, go ahead, Kevin.
Could you remind me what the change in the membership is? The physician total, the non-physician total, and the number of FDNY directors?
So the number of FDNY directors went up by 3, I believe. And the number of other physicians went up by 1 or 2. And that's where the balance of the membership remained intact. We did go from an even number to an odd number. We felt that would be easier in terms of having a majority.
And then the Medical Standards Committee, am I reading that correctly, that the chairperson is always municipal FDNY?
So that was discussed. The chairperson is municipal FDNY, considering that the chair of REMAC is generally not, because the chair of REMAC is usually a non-FDNY municipal person.
Is that stipulated that the chair
It's
is
not statutory, no. I actually, I don't believe we made that statutory. Let me see. We did not make that statutory, no.
So potentially both the chair of REMAC and the chair of Medical Standards could be FDNY.
Yes, unless somebody wants to make a motion to change that.
And vice versa.
I'm sorry?
And potentially
yes,
the chair.
Right. Correct.
Right.
Yeah, Joe, I don't think that's in statute. I think it's something for discussion. And we have always had a void of willing, active volunteers. So we should think about that.
Right. No, listen, I hear what you're saying. The understanding, the rationale behind it was that because the fire department is the largest agency and manages the 911 system, having a REMAC chair that was not a fire department physician would be appropriate. It is not statutory though, so Kevin is correct in that in our current breakdown, it could be a FDNY person for both. You raised your hand.
Yeah, you're misusing the word statutory, so I want you to understand. Statutory means by law, like Article 30. What we're talking about here is bylaws. Bylaws is whatever we agree. Or whatever.
Correct. I'm sorry, you're right. I did misuse that word.
So right now, it says that medical standards is municipal, and it says 0 here about the chair of REMAC. But remember that you guys vote. So if you don't like the chair, you don't want him to be a person. You don't.
Just being friends? I would love that.
Correct. Okay. Any further questions? Lauren, you have your hand up. And
Yeah, I see
Paul
that.
has his hand up.
Yeah, Paul wrote in the chat here, I disagree with assigning roles based on agency alignment. They should be based on individual merit. I agree with that. I can't start a motion. I'm not on the REMAC, but I agree with that.
I'm not really sure I understand what you mean, Paul.
Okay, can you hear me?
Yes.
I make a motion to strike all agency alignment from individual titles in these bylaws. So everywhere you see municipal, non-municipal, just pull it down. If I'm happy to maintain the seats that the fire department feels so strongly about, and I believe that those people belong to have voting seats because of their collective production in our region. And I'm happy for this change, allowing some of these very bright-minded physicians to come in and have votes. But I disagree with having votes based on an individual's agency. It presumes they're going to vote a certain way, and it removes the concept of free thought from an academic professional.
I guess I don't understand because the breakdown of the membership is by affiliation, meaning they're the fire department's affiliation, the Greater New York Hospital Association. Are you suggesting that all of those
and the leadership
should be removed?
Then I guess the leadership pieces, Joe. I'm sorry, I'm on the road now. I apologize, but then I guess the leadership pieces. That's my motion. Feel free to have it seconded or not, whatever.
Well, I mean, to discuss it, I just want to understand it, but we would need a second to discuss it.
I'm actually not clear what's being proposed.
I'm not really
I think
clear.
not to speak for Paul, but I think he's suggesting that for where it says chairperson, vice chairperson for medical standards, that not be restricted to municipal, non-municipal. Paul, is that what you're saying?
Yes, that's what I'm saying. And I can't see, Joe, if there's any other places where it's been written in a position of leadership.
The only other place that it's mentioned is under the type of person that is a paramedic program medical director. There are 2 seats. There's a municipal FDNY seat and a non-municipal. But I guess it's not specifically.
Joe, he's not talking about that chart. Take that chart away. He's talking about the section down below. Move where it says.
No. I apologize.
It's okay. Listen, I know what he's talking about.
Trying to talk
right here, where it says
3 people trying to talk for me.
Standards Committee. There is 2. It defines under chairperson. It defines municipal FTNY, and under vice chairperson, it defines non-municipal. I think the purpose of that language was not to define the chair or the vice chair, but to suggest that the representatives for medical standards be 1 a municipal person and 1 a non-municipal person. That was the purpose of that language. We could correct it by removing chairperson and vice chairperson because it doesn't necessarily have to be the vice chair and the chair. and then it would be a municipal person and a
I think that's a good
non-municipal
idea.
person. But if we do that, we have to start the process of reading these bylaws again, just so everybody's aware. That's not a bad thing, but it's the facts of how we do this.
So, Joe, my hand is still up. Can you hear me?
Yes, sir.
I withdraw my motion. I withdraw the motion.
Okay.
Paul, I was on your side for a moment there.
All right. Does anybody else have any questions?
Yeah, I mean, I'm confused. Doesn't the people that are on medical standards, aren't they pretty much already on REMSCO? Like, why is that even?
No, it's not. So please, let's not. The medical standards is a committee of medical directors and EMTs and paramedics. The REMAC is a committee of regional stakeholders. And it happens to be that a lot of the people that are on medical standards are also on REMAC, but the REMAC is compiled of appointments from different agencies, as well as community people that fit the descriptions of the seats that they're in. So medical standards has 2 appointments to the REMAC as a medical standards committee. Those are not specifically, just because it happens to be that there's overlap, and a lot of it is not because you're on one, therefore you're on the other. Does that make sense, Kevin?
Donnie, go away, Donnie. I'm gonna kill you.
So Joe, that means that you shouldn't put chairperson and vice chairperson. It should be municipal and non-municipal members.
I agree with what you're saying, and I think that that's the right way to do it. If we do that, we'd have to restart the process. Is that correct?
That is correct. And besides, there's no motion right now because he withdrew his motion. I don't know why you're still talking.
No, he's going to David.
All right, so I'll make a motion to remove chairperson, vice chairperson from the medical standards committee designation.
So there's a motion.
No, the other guy is.
I second it.
Thank you. Okay, so the motion on the table is to remove the language that says chairperson and vice chairperson under the bullet of medical standards committee, and have it just read municipal, FDNY, EMS, and non-municipal. Any discussion on that? I mean, we've kind of had the discussion already, but any further discussion on that? All right, seeing none, Marie, if we could vote on this change, do we have to vote on it?
You have to vote on it. It's an amendment. You have to vote on it. If it fails, you can go back to the original bylaws right now.
Okay, so let's vote on it. And if it passes, then we'll start. I'm sorry, Paul, you have your hand up.
One more question. I'm sorry.
Go ahead.
Does that mean the medical standards can nominate people who are neither the chair nor the vice chair?
That's what it would mean, yes.
Okay.
Paul, Ben Zabar.
Sorry, I'm just confused because the bylaws is saying medical standards is a subcommittee of REMAC. So it seems like the power is going from REMAC down to medical standards. It's not that medical standards is a separate group that is nominating and sending people up to the REMAC. And so if medical standards doesn't have a bylaws, I know it's a little confusing, but it doesn't sound like they're 2 totally separate groups. It's a subcommittee. It's a subdivision of.
It is a subcommittee, but the membership of that subcommittee is more global than just REMAC. REMAC is stakeholders in the entire system. Medical standards is compiled of the medical directors and EMTs and paramedics from every agency in New York City. Every medical director has a seat on medical standards, and that's why there's a lot of people that that are not here. And that we'll have to address that. But the point is that medical standards is the medical directors of every agency. These are specifically appointed either through their affiliation or by the REMAC. Does that make sense?
Right, but is that vice chairperson? They're not appointed.
So right now the motion is to remove vice chair and chairperson. Those have been voted on seats, and that's where we're up to. Let me move on though, because you have your hand up.
Yeah, I thought maybe I should explain it a little bit better. Theoretically, although not in practice, that medical standards, with the exception of these 2 seats, medical standards and REMAC can have totally different people on them. Totally different, except for these 2 overlap. Okay? It turns out that it's not the case. There are a lot of people who are on both committees, but according to the bylaws, the two committees could be completely disjoint. This one thing here, if you remove the words chairperson and vice chairperson, simply guarantees that should there ever be a time when medical standards is completely different than REMAC, at least REMAC will have two people from medical standards on it. That's what this guarantees. But otherwise, legally, they're two completely disjoint committees. In practice, tremendous overlap all the time.
Thank you. Mark.
Right. Going to what Ben's question, I think in the chat about who nominates, since it had been designated as chair and vice chair, that was an automatic, you knew who it was. In the section down below, does that need to be added in, how those people are selected? Is it the REMAC nominating committee, or is it a vote of the
So I would say because
standards?
it's representation from the medical standards committee, if the REMAC, in practice, we have had a vote for the medical standards chair and vice chair lately. That is not in the bylaws, but that is in practice how we've done it. What would have to happen in the future is if, let's say, a chair decided that they didn't want to vote and they wanted it to be an appointment, they could appoint a chair and a vice chair who could then choose anybody from their committee to come to REMAC. And it would be a letter to REMAC saying, as the chair of medical standards, I appoint so-and-so. And that would be the answer.
Why do you say that?
Because that's, I mean, again, if you appoint a chair of a committee, that committee has a right, if we're saying that medical standards is appointing two people to REMAC, medical standards then can appoint two people to REMAC.
Yeah, but I'm not sure if the chair of medical standards, that doesn't say it. It could be medical standards as a whole has the vote. It doesn't say one way or the other. I mean,
but that committee has a right to form their own bylaws and develop that. We can do that at another time, but let's do this now so we can get off this call because it's already 7:40.
That's correct.
Right now, the motion on the table is to remove the language for chairperson and vice chairperson. That is a seconded motion. Is there any more further discussion on that motion?
And that requires only a majority, not two-thirds.
All right. Seeing no further discussion, Marie, if you can have a roll call vote to make this amendment.
Okay, I just want to be clear. The amendment is to change number 15, Medical Standards Committee. We're removing reference to chairperson and vice chairperson. It's going to be A, municipal, and B, non-municipal. Correct?
Yes.
And this is a REMAC. This is within REMAC's jurisdiction, not REMSCO.
This is all within REMAC,
Yes.
correct?
Okay.
Okay, let me just write this down. So this is REMAC bylaws, med standards, community. Okay. Okay, so answer in favor, oppose, abstain. Robert Winchell,
In favor.
Nick Alexandru,
In favor.
Kevin Munjal,
In favor.
Dario Gonzalez,
In favor.
Glenn Seda,
Opposed.
Bradley Kaufman,
In favor.
Doug Isaac.
Opposed.
I'm sorry, Doug?
Opposed to this change.
Nathan Reisman,
Opposed to this.
Jeff Rabrich,
Favor.
Reed Caldwell,
In favor.
Lewis Marshall,
In favor, in favor.
thank you. Wallace Carter, Wallace Carter, Stuart Kessler,
It's Laura, in favor, Dr. Abicoli.
thank you. Peter Wire,
Abstain.
Paul Barbara,
Opposed.
David Benelli. David-
Against.
Against? Timothy Stiles,
In favor.
Mark Cantor,
In favor.
Joseph Bove,
In favor.
William Fisher.
In favor.
I think Dr. Krupe had to leave. Dr. Krupe? Jessica Van Voorhees? Arthur Cooper? Dr. Cooper? Four, 5, 6, 7, 8, 13, yes, 1, 2. So we have 13 in favor, 5 opposed, 1 abstention.
Motion passes. Okay, so we will begin the reading process at the next meeting. Any unfinished business?
Wait, Joe, can I ask a question about that?
Yeah, ask away.
The idea of this reading is that if there's any change, it starts all over.
Yes.
That seems, it seems a little silly.
Well, you'll have to argue with Robert. You'll have to argue with Robert Rules, who started this in the 1880s and has gone through 11 editions and didn't go to medical school, but that's the rule.
Yeah, everybody needs to read these bylaws when they come out for the first time
By
and
the
make your argument then.
What is the majority of REMAC?
I'm sorry?
What is the majority of REMAC?
The quorum for REMAC is 16.
A majority is 16. Well, you only had 13 right now. So how could this have passed if you had only 16 in favor?
I didn't believe that you needed to have 16 in favor. You just need, this is not a statutory vote.
You don't have to have a majority of the quorum.
Yeah, it's not a CON vote.
What do you're the parliamentarian. If I'm wrong, then tell me.
Maria's right.
You have your hand up, but just give me 1 second. You go ahead.
I'm thinking about it. I don't have an answer.
All right, so Josh, what's your
Professor,
I'd have to think about it.
I love you. Maria's right.
Josh Buckland? What did you had your hand up?
I'm sorry. I'll wait for my question. It's about the vaccination.
Okay, no, you can ask it now. You did just thinking. I can see the smoke.
When does the vaccination protocol go into effect? Does it have to go to SEMSCO or does it go into effect?
Yes, it would have to go to, well, SEMSCO said that we could do it. I think we'd have to inform them of it.
So does that mean it could go into effect before January? Is that?
I think that if
the question is that Maria's right, and therefore this starts all over again. You've got now 3 more meetings.
Okay.
About the vaccinations.
So Josh, I have to get back to you on that. I don't have the answer.
Thank you.
I have to ask Ryan and the state what the answer to that is.
Okay, thank you.
No problem.
Joe,
Yes.
Joe, this is David.
Go ahead.
Since we're already going to bring this back for 3 more readings in 3 separate sessions, I would like to revisit Peter Ryer's motion regarding the MISNY non-EM physician.
Okay.
I think there's a lot of merit to what he says.
So make a motion.
I am making a motion.
And is there a
What's the
second?
motion? You have to tell us what it is.
I guess Peter is Peter on the is still on the con?
You're moving to remove the words non-EM physician from the specification.
That is correct.
Of the Society of the State of New York Physician Delegate.
Second.
Now you need a second.
Seconded by Brad. Okay, any discussion? I mean, we already kind of had the discussion. Let's vote then. Lou, wait, you have your hand up, so I don't know if this pertains to what we're talking about. Lou?
Put his
Yeah,
hand.
sorry. Hi, I did have my hand up, but I mean, I'm cooking dinner, so
Was
I
that
forgot what I had my hand up for. So, but if anyone wants tacos, come on over.
Thank
So
you.
Joe, I have some discussion.
Nice.
Okay, go ahead, Brad.
I mean, I guess it's so if if we decided that the previous motion failed,
Didn't.
then we would be voting to,
We decided that it did pass.
Yes.
gotcha, thank you.
Okay, so now so the vote would be to remove the language for non-EM physician, and it would be any physician designated by the Medical Society of the State of New York. If that passes, that will go into the new reading of the bylaws, and we'll move forward. So Marie, if you could vote for us.
Yes,
Actually,
sir.
Hold on, it's not a statutory vote that requires a roll call. We could do this in the Zoom chat.
No, you legally, because of the way the state has just said, because of the governor's executive motion to allow you to even have these meetings, it's got to be by roll call.
Go ahead, roll call away.
Okay. Okay, so we're voting on removing the emergency medicine requirements from the Medical Society
So the
seat.
non-emergency medicine, the language non-EM physician is being removed.
The parentheses, get rid of the parentheses with everything in it.
Okay. Okay. Robert Winchell,
In favor.
Nick Alexandru,
In favor.
Kevin Munjal,
In favor.
Dario Gonzalez,
In favor.
Glennis Seda,
In favor.
Brad Kaufman. Brad Kaufman,
He stepped away, come back to him.
Doug
The
Isaacs,
second, so he's in favor. Yeah.
In favor.
Nathan Reisman,
In favor.
Jeffrey Rabrich,
In favor.
Reed Caldwell,
In favor.
Lewis Marshall,
In favor.
Wally Carter, Dr. Carter, you still there?
He wasn't here before.
Peter Wire,
In favor.
Paul Barbara,
In favor.
David Benelli,
In favor.
Tim Stiles,
In favor.
Mark Cantor,
In favor.
Joseph Fove,
I don't see him. He might have stepped off.
William Fisher,
Quorum anymore.
Robert Krupe,
He stepped off.
that's right, Art Cooper. Okay, well,
Brad is back, Marie.
okay. Brad, are
sorry.
you in favor?
In favor.
Okay.
So that passes.
You still have a quorum?
Dr. Bove, did you come back? Dr. Fisher? 1, 2, 3, 4, 5, 6, 7, 8, 10, 11, 12, 13, 14, 15, 16. Yes, we have a quorum because we need 16. We've got 16 in favor.
Thank you. Okay, so starting next month, we will, actually, there is no meeting next month. So starting in January, we will begin the reading of these bylaws with those two changes.
Okay.
All right. I will entertain a motion to adjourn at this point.
So moved.
Thank you, everybody. Appreciate
Thank you.
the time you guys spent on the call. Thank you.
Have a good